Good evening, and welcome to AUA's Prostate Cancer Update 2024 Expert Guidance for APPs live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this other activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. All persons in a position to control the content of a CME activity are required to disclose to the AUA as the ACCME accredited provider all financial relationships with any ineligible company, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so they can make their own judgments. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify the accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models, and generative AI. The AUA would like to thank Astellas, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc. for providing independent educational grants in support of this webinar. Finally, I would like to introduce and extend a special thank you to our course director, Ms. Meredith Donahue, for her time, talent, and expertise in developing this program. Meredith Donahue is a nurse practitioner at Vanderbilt University, specializing in urologic oncology. After completing the fellowship, Meredith's passion in urology clearly fell to urologic oncology. Meredith primarily cares for patients with malignancies of the kidney, bladder, and prostate. She manages a non-muscle invasive bladder cancer clinic, which involves installation of bladder chemotherapy, as well as managing its side effects and advocating for cancer survivorship. Along with this, she closely co-manages advanced prostate cancer patients in the Comprehensive Prostate Cancer Clinic. When counseling these patients, Meredith utilizes a compassionate, empathetic, and multidisciplinary approach. This clinical focus has dovetailed into a collaboration with VUMC Medical Oncology and the hereditary cancer clinics regarding the research and applications of genomics in prostate cancer. I will now turn the course over to Ms. Donahue.
Great, thank you. Hi, everyone, and welcome. Thank you so much for joining tonight and taking time out of all of our busy days. I know that. A couple things before we get started. This is going to be a live panel discussion, so we want this to be interactive and informative, and please ask questions as we go along. The goal of this activity, based on documentation from the AUA Advanced Prostate Cancer Global Needs Assessment, the AUA is providing additional education to update APPs on the latest advancements in the management of hormone-sensitive prostate cancer. All right, these are our learning objectives. We're going to start with the basics of prostate cancer screening, early detection, and identifying risk factors for prostate cancer. Then we'll get into diagnostic tools and techniques for diagnosing prostate cancer. That'll include imaging and biopsy. We're going to look at biomarkers, the use of biomarkers in both in diagnosis, early detection of prostate cancer, as well as in later stages for therapy. We're going to look at and talk about managing advanced prostate cancer as well as metastatic prostate cancer, looking at systemic therapies and including treatment intensification. And then last, we're going to talk about survivorship, and that will include discussing a multidisciplinary approach to treating patients with advanced prostate cancer. I have the pleasure of welcoming our faculty today. I'll start with Dr. Kelvin Moses. He is a very close colleague of mine who I'm lucky to get to work with. Dr. Moses is an associate professor of urology, the fellowship director for urologic oncology, and director of the Comprehensive Prostate Cancer Clinic at Vanderbilt University Medical Center. His clinical practice focuses on advanced prostate cancer, including several clinical trials as well as surgical management of advanced renal, penile, and testicular cancers. Dr. Moses's research is focused on addressing health disparities in urologic cancers, determining the role of health literacy and patient interactions with the healthcare system, and optimal care for patients with metastatic and/or castration-resistant prostate cancer. Next, we have Ms. Kara Kosis. She is a physician assistant at Chesapeake Urology. Kara has been a physician assistant since 2006. She started her career in the field of urology 17 years ago in inner city Baltimore before transferring to Chesapeake Urology, where she currently serves as the director of advanced practice providers. Kara works both administratively and clinically within this role and co-manages the Advanced Prostate Cancer Clinic within the practice. And last but certainly not least, we have Lori Gallman, is a nurse practitioner from Stanford. Lori joined Stanford in 2007, where she worked for over 12 years. She became the lead APP for the urologic oncology and radiation oncology teams in the Stanford Cancer Center in 2020. Her work highlights include improvement patient and staff workflow and APP independent practice, updating patient education, and implementing APP-led clinic for MRI-guided transperineal biopsies. Thank you all so much for being here, and let's get into this. So like I said, we're going to start with prostate cancer screening and guidelines. Although this is a talk on advanced disease and management of advanced disease, maybe we can make our goal to make screening better so patients don't have to experience advanced disease. So let's do a quick rundown of screening and early detection for prostate cancer. Kara, if you could get us started off with just the basic guidelines from the AUA on prostate cancer screening and early detection.
Sure. So basically, things have changed a little bit from anyone who's had a history of knowing how we used to screen. And there's a lot more involving shared decision making. So essentially, it's talking to the patient to analyze their willingness and to move forward with PSA screening. If there is an agreement to do so, basically the patients who have an average prostate cancer risk, which I will go over the more advanced in just a moment here, but between the ages of 45 and 50, they should have their initial PSA screening. If we determine that they have advanced risks, so that's anyone who is of African American descent, people have had known germline mutations, or if there's a strong family history of prostate, ovarian, or breast cancer, they're considered to be at an elevated risk. If that's the case, we move it up 5 years. So the screening should begin at 40 to 45 years. And it's important that the PSA velocity is not a sole monitoring measurement to move forward. Something else that's sort of changed a little bit is we're not, going on like one PSA alone. This should be repeated before we move on to some secondary biomarkers, imaging, or biopsy. If we do find that they are of low risk and the PSA is normal, screening is then recommended on a 2 to 4 year interval for the ages of 50 to 69, or based on personalized individual screening or to discontinue the screening. If they do have the elevated PSA risk, there should be, as I mentioned, that confirmatory PSA. The DRE is optional. And if we find that they should be moving on, then we'll go on to the elevated risk evaluation.
Great. Thanks, Kara. You touched a lot on the men with an increased risk of prostate cancer, but Dr. Moses, if you could elaborate on that and the importance of identifying these men who are at higher risk of developing prostate cancer.
Yeah, it's very important. As was already described, men at higher risk, number one, are recommended to be screened earlier. Number two, knowing that they're higher risk sort of informs how you'll follow their PSA. So if they have a history of a relatively low PSA and it increases significantly, then it needs to be investigated. Certainly older men, this is a disease of aging. There's multiple studies that show Black men tend to present at a younger age, present with higher risk disease if localized, and more likely to present with more advanced disease as well. And this is a sequela of screening and of treatment disparities, and those need to be eliminated. And then obviously anybody with first-degree relative, one first-degree relative raises your risk about double, and first-degree meaning dad, son, or brothers. And then multiple family members certainly place you at increased risk as well. And I'm sure we'll get into some genetic testing later on in the discussion. And then certainly on exam, if you feel anything that's abnormal, it needs to be investigated further with either imaging and or biopsy.
Great. Thanks, Dr. Moses. And I think, thinking about men, Black men, is we could get into a whole other talk about social determinants of health and how that plays a role in diagnosis of prostate cancer. Kara, back to you on this one. How do you use biomarkers for early detection of prostate cancer? We have so many options now that we didn't have 5, 10 years ago. And how do you use that to help you risk stratify, help diagnose prostate cancer as well as in risk stratification?
Sure. So I think, again, a lot of this is a lot of shared decision making. Patients aren't necessarily keen to move forward with biopsy. And I think the recommendations, we were over biopsying people. So one of the things that we talk about is that, there are these available tests that sort of help us stratify what the chances are that we are in fact dealing with a prostate cancer. There's certainly several options that, that exist, but essentially it's helping to give us the information of, if we should move forward, given the likelihood that we are in fact dealing with a cancer or not. It also helps us know if we, have had a negative biopsy that maybe is not targeted, what are the chances that there was something that was missed, or helps us, figure that out a little better to keep the screening proper, that we're making like the best decisions to move forward, and whether or not they should have, a potential, different imaging to kind of look at things a little bit further.
Right, right. Yeah, absolutely. And I don't know about you at your practice, but I know we'll have men come in and, they heard about this test or heard about that test, and their friend had this one and their other friend had that test, and can I get that? And also navigating that with patients that, we could get these tests on every single patient, but that's not going to be useful for us. So it's important for the APP to understand when to use these adjunctive tests, because they can provide a lot of really good information, but sometimes we don't always need them. So thank you for that. So that was the quick version of the AUA guidelines on prostate cancer screening and early detection. Now let's get into imaging as well as biopsy techniques. I'll get us started with discussing prostate MRIs. Prostate MRIs are one of my first go-tos. I can tell you that. But using it in early detection of prostate cancer, it's in the initial diagnosis or initial presentation of an elevated PSA, the AUA recommends that the clinician may offer an MRI prior to biopsy. However, the AUA does strongly recommend in men with a history of a negative biopsy but a rising PSA to utilize a prostate MRI. It's important for APPs to understand the PIRAD scale. This has certainly changed over time, but PIRADs typically, I know I recommend a biopsy for PIRADs 4 or 5. PIRADs 3 lesions, that's very much a shared decision-making conversation with the patient and discussing all of those elevated, if they have any of those elevated risks that Dr. Moses and Kara talked about. Also, I'll just note that having a prostate MRI on hand is also good for future surgical planning or radiation planning. Now, once we have that prostate MRI that does show a suspicious lesion on the MRI, that's where we have the conversation of biopsy. At our institution, we're doing both transrectal and transperineal biopsies. Ultimately, I leave that decision to the patient. It's a long conversation explaining each of those procedures. There are certainly cases where I will encourage them to go one way or the other. I'll encourage a patient to have a transperineal if I know they're going to be at really high risk of an infection. I might push them more towards a transrectal if I think they're going to be at high risk for going into retention after a transperineal biopsy. But generally, I use this as very much a shared decision-making conversation. Lori, now that we've quickly gone through prostate cancer screening, early detection, and diagnostic factors, once a patient is diagnosed with prostate cancer, how do you use conventional imaging?
Thanks, Meredith. I'm going to jump back to the MRI really quickly. You had some really good points. I just want to add, and somebody had asked what the infection rate is. It's actually, we thought with transperineal biopsy that it would be lower infection rate compared to trust, but the studies out there currently show that they're quite similar. In fact, there was a study in the European Association of Urology in 2024 comparing trust and transperineal, which actually showed similar results. I think it looked at over 600 men. The only difference was really that the trust, you use antibiotics, and for the TP biopsy, you don't. In my practice, I've actually noticed that, and I think it was also in this study, that the pain level is actually slightly higher in transperineal biopsy. But yeah, we certainly, if there's anterior lesions, I think TP biopsies tend to be a little bit better just because of the placement. You're going through the perineum rather than the rectum. But yeah, so the thinking is that transperineal is supposed to have less risk of infection. I think it is pretty comparable from just the few studies that have been published.
Yeah, great points there, and great point on the any anterior lesions also would be a reason to encourage transperineal. Are you doing transperineal as the patient awake, asleep, nitrous? How are you doing that?
Great question. So yeah, I actually was trained on patients being awake. So it was pretty challenging in the beginning. And once you learn your technique, it's much better. But it's funny because now we're actually backtracking and we're making the opportunity for patients to go in the OR as well as outpatient. We have such a backlog that we're actually using all forces. So the OR, the transperineal, the truss, we're really trying to do, whatever we can get. But there's definitely patients that will just push back and will not have this biopsy unless they're under anesthesia.
Absolutely. Yep. And just a quick note in the chat. Yes, this is transrectal and transperineal fusion biopsies. Okay. Conventional imaging.
Yes. So thank you. Yeah. So conventional imaging consists of a CT and bone scans. And these are basically staging studies that help determine if the cancer is localized to the prostate or has spread outside the prostate. And staging is really necessary for treatment planning and predicting outcomes. And, intermediate risk patients tend to have a Gleason score of 7 or higher and a PSA 10 to 20. High-risk patients have a Gleason score of 8 or higher and a PSA of more than 20. Now, the CT assesses for soft tissue and lymph nodes to assess for distant metastases of the lymph nodes going to the bone, the liver, the lungs. However, there is limited sensitivity in detecting extraprostatic spread in high-risk patients. The bone scan is a nuclear medicine scan that specifically evaluates the bones. Now, there is high sensitivity for the positive findings. However, there is low specificity, meaning that there could be a high number of false positives as well. There is also lower detection rates for patients with lower PSAs. In general, both of these studies do not detect micrometastases very well, and therefore patients can be at risk for possible understaging and underestimating, which can impact treatment decisions and potentially patient outcomes.
Perfect. Thanks, Lori. And I think that leads us right into what Dr. Moses is going to speak about. And when are we utilizing PET PSMA for staging? When should we use it? And also, how can it? This is getting ahead of ourselves here. But how can PET PSMA imaging be utilized in treatment for advanced disease?
Definitely. Thank you. So I'm sure everybody's aware of what PSMA PET is, but it is a form of PET scan that uses the prostate-specific membrane antigen as the localizer. And so you can find disease sometimes not necessarily easily seen on a CT or MRI or on a bone scan, and can guide therapies, particularly for people with maybe low volume metastatic disease or extrapelvic nodal disease. The guidelines recommend PSMA PET if there's PSA recurrence after surgery or radiation. And you can use that as an alternative to CT bone scan. It's kind of convenient for patients because it goes from 2 or 3 imaging down to 1. Certainly is used for more advanced disease. And again, we'll get into this later in the presentation. But certainly for men with PSA recurrence, metastatic disease, hormone-resistant disease, and those who progress through therapies, PSMA PET can be used. And it's a very sensitive test, maybe not necessarily extremely specific, but certainly very useful. And we use it quite a bit in our center here at Vanderbilt.
Kara and Lori, I'm just curious. I know I've had to do, over the last, let's say, 4 years, a lot of peer-to-peers to try to get PET PSMA scans approved. Have you noticed, are you doing less? I feel like I'm doing less peer-to-peers, that insurance is approving them when we want them now. But I'm just interested to hear your experience with that, with approval and all.
Yeah, I think in the past couple, it was initially very challenging. And I think one of the questions is, can you still use CT and bone scan if it's not approved? And the answer is absolutely. Those are the historical, conventional imaging studies that have been done. They're still great. It's just the PSMA PET is more sensitive and is better. Mm-hmm. But I think in general, at least from our end, peer-to-peers have been a lot less. And if you're, it's for the rising PSA after initial localized treatment. They're certainly covering it. So in most cases, if you can give a good story, at least from our end in California, they are covering it.
Yeah, interesting to think about the different states.
So yeah, we're having the same experience that generally it tends to be covered much more easily. It seems like the issues we have sometimes are more of a portion of it not being like the test is covered, but like the tracer is not, or sometimes with our like medical assistance programs. I think that somebody had asked in here too, if there was
was there that said something about, was there like a specific thing? So the specific PSA, and I think really the guidelines are that it has to be rising for the insurance to approve. And also we can use it for, initial staging, but really, at least at this point, we still cannot use it for just routine management to compare, 1 year to the other. Although I have, believe it or not, heard that some people have had success with being able to do this. It's just, I personally have not myself.
Yeah, great. Thanks,
Can I
everyone.
point out one more thing with
Oh,
the
absolutely.
PSMA PET that I really like is that beside the fact that it shows that, if there's lesions outside the prostate, it's actually super helpful. It like lights up like a balloon in the prostate. So if you think there's some discrepancy with the MRI or the biopsy and it doesn't seem like you got all the cancer, it's super helpful to actually see if you're going to have to do a repeat biopsy. So I think there's just so many aspects to this imaging that are just really great.
Yeah, absolutely. And I think we're just learning more and more about it the more we use it. All right. Well, that is the perfect segue to talk about advanced disease. There we go. So I'm going to get us started with the mechanism of testosterone suppression. I know I always remind myself of this picture and have this picture seared in my brain because we're talking about it every day. But as we all know, prostate cancer is an androgen-dependent disease. The androgen receptor is highly expressed on prostate cancer cells. With prostate cancer, we see testosterone bind to the androgen receptor to promote survival, growth, and proliferation. ADT results in the regression of disease by either reducing the level of androgen or blocking the effects of the androgen. ADT is used in both localized and advanced disease. Again, I just think it's so important for us as all providers, definitely APPs. I think we're a lot of the ones that are starting men on hormone therapy to have a very clear understanding of what we're actually doing when we start one of these therapies. Quickly, GnRH agonist versus antagonist. The agonist stimulates the release of FSH and LH, therefore increasing testosterone. That's a negative feedback loop to tell the testicles, cut off, stop making it. And then the antagonist tells the pituitary gland to decrease FSH and or to stop FSH and LH production. And I try to, especially when explaining side effects of hormone therapy, I try to make sure men have as much understanding as they can about each of these processes. I think that helps them to understand that this is a systemic treatment that we're doing. And then I always want to make sure we mention bilateral simple orchiectomy. I know Dr. Moses is a big fan of this, and especially in those older men who getting a shot, coming in to get the shot every 3 months, or side effects might be really terrible. I find that doing the orchiectomy is a great option. Side effects are tend to be less. So sometimes I have to ease them into that conversation, but we do that, include that in our conversation and men with advanced prostate cancer.
Meredith, if I can just add one thing, if you're
Please.
counseling on orchiectomy, so I don't tell them I remove the testicles. I tell them I remove the tissue that makes testosterone. And what we do is a subcapsular orchiectomy. So we will incise the capsule of the testicle, sweep out all of the testicular tissue, and then close the capsule back up. So they still have their testicles in place. They have a little bit of shock about the wording or the appearance or whatever. You can set them at ease and say, on hormone therapy, they're going to shrivel up anyway a little bit. And with the surgery, it's cost effective. It's a one-time deal. The hot flashes are less severe. You don't ride the wave that comes with the shot. And, if you do a subcapsular version, you really don't even change appearance.
Yeah, that's great. Those men are happy after that surgery. Well, let's get into it. Kara, how do you typically choose between, or when do you use an agonist versus an antagonist when starting hormone therapy?
Sure. So I think, the biggest thing just to point out is that when somebody is going to be on an antagonist, it's going to reduce their PSA and their testosterone fairly rapidly. So we're talking a matter of days versus the agonist, which is going to take, several weeks. Okay. So I think that's really the big distinction. So when, the goal really is to bring it down. And, I think what we just need to really consider is, how quickly we want that to happen. And if somebody has, advanced disease, they have metastatic disease, we usually don't want that to happen. We want it to happen as quickly as possible. So moving to the antagonist generally is the preference, of choice. Other things that I kind of think about, so, not having the metastasis necessarily in there, but like, is the duration of their therapy? Are they getting, is the goal for them to be on this for 3 months? Or are they supposed to be on this for 2 to 3 years? The other thing is there's, compliance. Is a patient willing to take, a pill every day? Are they willing to, take a shot once a month? Are they willing to take a shot every 3 months, 4 months, 6 months? So it really depends, what they're sort of willing to do. Other things I want to think about too is if they are taking an oral medication, there are some drug-drug interactions to consider. So we need to look at, what they're currently on. Is there a possibility for that? And then it's sort of been dancing around the periphery, but we do believe that the antagonists do have some cardiovascular benefit. I know there's still sort of research pending on this, but if we have someone who's really a cardiac, nightmare, we want to think about some things in there that maybe that could be beneficial in the long run. And if someone is going to be on a shorter course, as their testosterone was quick to go down, there's also some quicker recovery with the antagonist. And then I'd say, lastly, the biggest thing is, some insurance things. Insurance is a crazy thing that it views injections as a procedure. It views pills as medication. And so sometimes there's one that's covered over the other because of the way that the, insurance sort of sees things, even though they all accomplish basically the same thing.
Yeah, that's great. And I know we have been using the oral therapies, Relugulix, a lot more, and getting that approved more as well. And men have been pleased with that. I see a question in the chat talking about a holiday from ADT, and that is certainly reasonable. In the setting of, yep, Dr. Moses got it there. Not metastatic. If a patient is not metastatic, we will do intermittent hormone therapy or a holiday. So if it's a patient with a biochemical recurrence, imaging is negative, but PSA is rising rapidly, then I'll start them on intermittent therapy. And I do educate them that cancer outcomes, comparing men who are on continuous hormone therapy versus intermittent therapy, cancer outcomes are the same. It's really a side effect management thing. But again, that is in men who do not have metastatic disease. So let's, Lori, if you could talk, let me go back one. There we go. Talk some about the disease states of advanced prostate cancer. I know when I'm treating these men, I kind of have to go back, stop. All right, which bucket am I putting them in? And then go from there. So it's important to have a good understanding of each of these disease states.
Yeah, sounds good. And I'm going to even take it one step back. So, traditional treatments for localized prostate cancer, of course, are surgery and radiation. However, 20 to 30% of men will develop a rise in the PSA, and that's called biochemical recurrence. And the biochemical recurrence without metastatic disease is basically the rise in PSA without any evidence found on imaging of spread outside the prostate. Now, if you've had a radical prostatectomy, we're looking for that PSA to be greater than 0.2. I know in our clinic, we actually will try to hold off until it gets closer to 0.2 on 2 different occasions, although patients are kind of quick to want to get that referral over to radiation. So, of course, we'll work with them. And then if somebody's had radiation, we're looking at a PSA increase of more than 0.2 above the PSA nadir after radiation. And then treatment for this can be salvage radiation, it can be salvage surgery, or anti-hormone therapy. Now, metastatic hormone-sensitive prostate cancer, as we were just talking about the ADT, this is the prostate cancer that has metastasized or now spread outside the prostate. And these patients are responsive, either they're responsive to ADT or testosterone suppression therapy, or they have not yet tried ADT. There's been an increase in this diagnosis over the past decade, most likely because of improved imaging sensitivity and changes in PSA screening guidelines. Now, most prostate cancers will eventually stop responding to hormone therapy in time, and then these patients now become castrate resistant. And now we have the castration-resistant prostate cancer. And this is where it continues to grow even when androgen levels in the body are very low or even undetectable. Non-metastatic castration-resistant prostate cancer is indicated only by that rising PSA level because it's not detectable on imaging. And oftentimes, these men don't have symptoms. The most advanced stage of prostate cancer is metastatic castration-resistant prostate cancer. And this is where it's spread to other parts of the body, the bone, the lymph nodes, other organs. And really, the goal for this stage is to shrink the tumor, stabilize the growth, control signs and symptoms that may include bone pain, weight loss, urinary symptoms, and really try to maintain any type of quality of life. Now, not all metastatic disease is the same. So we risk stratify based on the volume of disease, as well as the risk of disease. And this is going to help us for how we tailor our treatments. So if somebody has low volume disease, they might have one side of metastases, and they're going to have better outcomes and better prognosis than somebody who's going to have high volume metastatic disease. High volume is where you have at least 4 or more bone metastases in one area outside the pelvis or the spine. High-risk metastatic disease is going to include 2 of the following criteria, which is a Gleason score of 4 or more than 3 or more bone lesions, and or visceral metastases. Now, the patients that have the worst prognosis, the worst outcomes, have de novo metastatic disease. And this is where they're initially diagnosed with metastatic disease from the very beginning, and they haven't had any prior treatments.
Perfect. Thank you. And going way back here, but your point on the discussion of salvage therapy after localized treatment. I see a lot of men who had a radical prostatectomy, and then when that PSA becomes detectable, and you're right, that's very much a time for shared decision making. You know, if I see a man and the PSA has come back at 0.15, but he had Gleason 8 disease and positive margins, then I'm not going to sit around and wait until that PSA reaches 0.2. I'm going to go ahead and get that process started, versus maybe someone with 3+4 disease and negative margins and the PSA bumped up to 0.11, 0.12. I'm going to watch that and let that declare itself. So thank you. Thanks for making that point. And great points. Back to the advanced diseases, and Dr. Moses, if you could speak on the management and treatments of advanced prostate cancer. Like I said, I like to always have to get my head straight on which bucket. And then once I figure out what bucket we're in, then thinking about all the treatment options available there.
Yeah, definitely. And thinking of it as buckets or categories is very helpful. There's a lot of overlap in certain of the medications, and as clinical trials come out and many of these drugs get moved up earlier in disease state, then they certainly become options. For the most part, each one does have unique options, though. For men with biochemical recurrence, the guidelines, both the AUA and NCCN, recommend observation, meaning follow these men, follow their PSA doubling times, get the scans. Clinical trials are also available, and there are several now, especially with many of the advanced therapies being moved up in earlier disease state. We do not routinely start these men on ADT, however. So unless the PSA is just significantly high and you're very concerned, or is rising rapidly, and we think of doubling times of shorter than 10 months, then for the most part, you don't treat with ADT. For those with CRPC without metastasis, there are 3 trials, and right off the bat, I'm thinking of Spartan and Titan, but we do have all of the amides, that class of medication. So enzalutamide, darolutamide, apalutamide. Again, in these men, you want to get optimal imaging, ideally a PSMA PET, but certainly CT bone scan is reasonable. This window is probably closing faster than the industry folks would like, because as imaging gets more advanced, what is considered non-metastatic often is not necessarily so. For metastatic hormone sensitive, you have several trials, including Charted and Latitude, that show that multiple of the medications are available. And really now with Peace 1 that came out recently, we're even doing doublet or triplet therapy. So with Charted, you had the addition of docetaxel. With Latitude, you had the addition of abiraterone with hormone therapy. And then again with Peace, the Peace study, and not Arison's. Oh yeah, maybe Arison. Yeah, Peace and Arison's. You can actually do triple therapy. That has a lot to do with volume of disease, the patient's overall status, but the studies show there's not a tremendous increase in the complications and AEs, adverse events, with these therapies. And then for MCRPC, this is probably the most well-established. You have the oral medications, abiraterone and enzalutamide. You have chemotherapy with docetaxel, and then you can give cabazitaxel as a second line. You have immunotherapy. Sipuleucel T is not on here, but that's one of the options, as well as the PARP inhibitors. And then there are also what are called theranostic or radioligand-based therapies, lutetium, PSMA, and radium-223 that are available. So and then in any of these states, there are clinical trials. So when you're talking about this with men, bringing up these trials, you don't necessarily have to get in the weeds, but you can say, these show better overall survival, or most of them use either recurrence, radiographic progression-free survival as an endpoint. And so there's a way of explaining to men, number one, metastatic disease isn't necessarily immediately deadly. There's several options that can keep you alive for years. Let's talk about some of the risks and side effects of each one and see which one fits you the best. Again, depending on age, overall status, do they have significant heart disease? Do they have uncontrolled diabetes? Those can make a difference in what you would choose for therapy.
Great. That's awesome. We got a couple questions, a couple really good questions. One was back to intermittent therapy versus continuous therapy in men with biochemical recurrence. And does that speed up essentially the process of progressing to hormone resistance or castration resistance? I don't think I know any data that supports that intermittent or continuous would speed up that process. If anyone does, would love to hear it. And then there is another question about using Xtandi in biochemical recurrence, and that was the Enzamet study that's using ADT plus Xtandi in the setting of biochemical recurrence, so no evidence of metastatic disease. We have started doing that at our institution. Usually that is men with who have very high risk features and a rapid doubling time that we'll talk about using that. Okay, now,
that's actually EMBARK,
EMBARK, sorry.
CRPC, and then EMBARK for the biochemical recurrence. But yeah, you're right about
Yes. Thank you. Yep, EMBARK. So talking about treatments for advanced prostate cancer and management of advanced prostate cancer, kind of the hot topic is biomarker testing in prostate cancer. Let's see, let's start with Kara. Who should we be offering germline testing to in men with prostate cancer?
Sure. So I think the main thing is we want to make sure that we understand what germline testing is first. So germline testing is basically, is the cancer inherited as in your gene line, as in your germ line, because that sometimes is confused with the difference between the germ line and the somatic, where somatic is basically the cancer is at producing abnormal genes itself. Okay. And so we really need to think about germline testing for anyone who is metastatic. We should really think about it for people who have known mutations within their family, and anyone who has a risk based on their family history. So especially prostate, ovarian, breast cancers. We should be, having that discussion about, offering that. Furthermore, I think the other thing is this hasn't been done up front. So listen, people's genes are never going to change. So you can do that up front. But if they are progressing in their disease, especially if they've been on an oral oncolytic and now we're considering them for additional treatment, this is the time to be doing it if it wasn't done earlier on to, help phase in additional treatment options for them, specifically in the PARP family.
Yeah, that's great. Thank you. And I think also the NCCN guidelines, and I think I've got this on the next slide, that germline testing is certainly recommended in men with metastatic disease, but also those men with high risk localized disease, and really catching those men early in their disease states, and hopefully so they don't become metastatic. So we have on here some of the most common genes that are germline mutations that are associated with high risk or advanced prostate cancer. Dr. Moses, Kara touched on some of this, but what's the importance of using biomarker testing in advanced prostate cancer, both germline and somatic?
Well, it really guides therapy. So of the ones you see listed there, with BRCA2 being the most commonly seen mutation, it guides therapy. So it opens up the pembrolizumab, olaparib, rucaparib as far as therapies for men with mCRPC. And then it also helps when you're treating men early on, especially if they're younger. If they have these markers, they really have more aggressive disease. And so you really want to treat more aggressively up front. And so, as it says there at the bottom, early use of platinum-based chemotherapy, utilization of the PARP inhibitors, pembrolizumab. So for men, in their 50s, 60s, 70s, highly functioning men, you want to check both the germline and somatic to see if that opens up other options for them. It also can help, again, just to sort of reiterate, with clinical trials, inclusion criteria for clinical trials. Sometimes you need one of these mutations in order to be included. So we check it in pretty much all of our men that come through the comprehensive prostate cancer clinic.
Mm-hmm. And someone may have already mentioned this, but I also try to stress the importance that this is really good information for their family. That, and then they might say, well, I don't have any sons, so how could anyone get prostate cancer? But explaining that these mutations can increase the risk for breast, ovarian, maybe some colon, maybe some melanoma. And so it's important information for their family, and that will often get them perked up and listening. Okay, I think that's all we got in the advanced disease state. And let's move on to less science stuff and more of the patient care and talking about survivorship in prostate cancer, and specifically how do we utilize a multidisciplinary approach. Here is a quick picture of who is involved in a multidisciplinary team. Missing a lot of people, a lot of providers here. But let's start with Lori. We'll get into more of the survivorship and then get back to the multidisciplinary approach. Let's talk about side effects of local therapy. You know, a lot of men, like you said, a lot of men who undergo local therapy for prostate cancer do go on to progress with recurrence or metastatic disease. And even when we're treating them for metastatic or advanced disease, we can't forget about these side effects that come from local therapy that can last the rest of their life. So, yeah, what do you do with these guys?
Yeah, I do a lot of talking, a lot of education, because if you do it right the first time, I think, first of all, they're definitely going to need repetition to understand what's at stake. But, both surgery and radiation, they have similar cancer control outcomes for localized disease. So it's really a matter of, what treatment is right for them. And so it's all about really the side effect profile. And so, if you understand what their priority is and what they want, then that's really going to help guide them. And it is repetition, because I think a lot of times they're kind of in a cloud when they first hear they have prostate cancer. So they just want it out. And they don't really think about the side effects, which they don't have symptoms before they have treatment. And then they have treatment, and then they have all these symptoms and their life changes. So I've really learned to focus on what are their priorities, because, and I broke it down into surgery and radiation. So you have surgery. Of course, you're going to have the general anesthesia risks, the general risks with bleeding, infection. For this particular surgery, lymphocyte leak, anastomotic leak, bladder neck contracture. But the two biggest that I focus on when I talk to them during the pre-op, number one, they're going to have stress incontinence. And everybody's going to have stress incontinence once that catheter is removed. And what I tell them is that 90% of men, that leaking will significantly improve within weeks to months. And so I really hammer pelvic floor exercises, Kegel exercises, even pre-op, even before the pre-op, want to get them trained so that once that catheter is out, they can start doing them. Now, 90% are significantly improved, which doesn't mean perfection. It means just maybe drops, but still you're going to have 10%, even after a year, that are going to have ongoing incontinence. Those men, I always refer to my general urology colleagues for additional treatments. If they're bothered. So that's number one. Urinary incontinence is definitely a big bother. The second very big thing with surgery is, of course, erectile dysfunction. And so, men that don't have good erections going in are going to have, the same to worse coming out of it. So, it's, again, really important to get their history and their priority beforehand to know what they want out of it. Men who have good erections coming in may have, erections or good erections coming out, but we usually say about 50% will have erectile dysfunction. And what that looks like, meaning they might have erections or decent erections, is they might be on medications long-term. They might be on multiple medications. They might need a vacuum device or, penile injections. And so what we do is right after the surgery, once the catheter is out, we'll start them on a daily Cialis, telling them we're just getting blood flow to the penis. And we don't expect them to get erections, but we just want to, try to optimize success. So let's just start with that. Because what a lot of them, and this is really important, a lot of them will tell you before the surgery, I don't care about erections. I just want to deal with the cancer right now. But what they don't understand is once they have the treatment and then they want erections, if they don't start it as soon as possible, then they can be decreasing their risk of, optimizing success. So we essentially have an aggressive penile rehabilitation program, which includes the daily Cialis and then adding on-demand Viagra and so on and so forth at the check-ins. So that, I think, is the overview with surgery. As far as radiation, radiation is broken down into the immediate complications and then the late complications. And so once you're having radiation, either in the moment or afterwards, you can experience some fatigue. You can also experience some urinary issues, frequency, urgency, some dysuria, hematuria, also bowel problems, loose stools, frequent bowel movements, rectal discomfort, bleeding. These are some of the potential side effects. And again, you could have sexual dysfunction, but to a much lesser degree than you would for surgery. Now, late complications can happen months to years, and we actually see a lot of patients 5-10 years down the road in our clinics, and they're complaining of chronic cystitis, chronic proctitis, rectal bleeding in about 15% of patients, and hemorrhagic cystitis, where we're just having to constantly try to get those clots out. And some of these patients will send them over for hyperbaric oxygen treatments. But it is the minority of patients that tend to have these severe complications. For the most part, patients tend to be okay. One other thing to point out is this secondary cancer risk, which is about 0.3%. And this is usually bowel or bladder cancer after having radiation.
Yeah. Great points. And I think one thing with I have lots to add on to there, but I know our time is limited. I think one thing with men who are receiving or who have received radiation therapy is making sure they know that side effects could come 2 weeks after or 10 years after. I'll have guys come in and they're having new dysuria and they're saying, but I finished 6 months ago. And it's like, well, we could have years of this. So let's start working on it now.
Absolutely.
And same with before radical prostatectomy, you hit the nail on the head that men hear cancer, let's get it out, can't think about anything else. And then all of a sudden they're after surgery and it's like, I'm leaking. Why am I leaking? This isn't right. And I try to explain to them that it's going to take months and even out to a year. I prepare them for a year just to set that standard. But I try to say that in an encouraging way, that just because where you are here at 6 weeks is not where you're going to be at 3 months, which is not where you're going to be at 6 months, that it's going to continue to get better. So thank you for all that. Okay. And then let's get into side effects of hormone therapy. We spent a lot of time talking about different types of hormone therapy, but unfortunately, those things come with a lot of side effects. Kara, if you could dive into all of those.
Sure. Yeah. So, I mean, it's tricky, right? And I mean, I think one of the biggest things is, continuing even with just the ADT or the sexual side effects. So, with lowering the testosterone, it is more difficult, to achieve, to maintain the erections. Sometimes even, with the treatment. So, especially if they're having, some combination, like adding on radiation, it can be very frustrating. Fatigue is one of our biggest challenges. It just, I tell patients, testosterone gives you energy. We're depriving your body of testosterone. And so, I mean, I try to, as you guys are saying, cheerlead and, keep them through. And I, tell them it's usually not, it's debilitating, but, I think adding with sometimes adding like the doublet therapies, or if, just depending on the situation, there's a triplet therapy, they all have fatigue and now we're compounding it. So that can be very, very tricky. I think the biggest thing is with the fatigue, trying to encourage patients, to maintain as active as a life as they can. So even, mild exercise, those type of things, just keeping them going. We have added sometimes some psychostimulants in severe fatigue cases that, we do as a practice. I mean, it's like one thing happens, you're trying to make it better, and then there's something else here. But also equally problematic are the hot flashes that they just exist. Some people get very fortunate though, and they don't have them at all, which is pretty unusual. But most people do. There's just sort of behavioral things that exist, like watching like spicy foods and there's some practical things, but unfortunately there's no like approved treatment. We know that several things work off label to help, but there definitely is a struggle with hot flashes, especially if they're very severe and very affecting their quality of life. Loss of bone mineral density. We know that ADT does, affect, they can lead to osteoporosis. It can lead to just have osteopenia. It's somewhat unfortunate that it's not, a screening test, because I'll tell you, when they have to have a risk factor really to, be screened for these findings for the insurance to approve the DEXA scans. And I'll tell you that I have a lot of patients, probably more patients than not, that do have osteopenia at baseline, but, it's just not something that we're screening men for. So I think, telling patients to, take their calcium, take their vitamin D, and then putting them on appropriate bone sparing agents as necessary. The one thing, just, keep in mind, making sure that they're having appropriate dental clearance so that we're not increasing osteonecrosis risk. And then weight gain, yeah. So that's a big thing, is, having that, especially in the visceral area where people already, are having some weight gain problems. But yeah, it's a sort of compounded effect. Cognitive decline. So some people do notice some fogginess, or that, they're off in their mental acuity being on ADT therapy. And then there's some increased, cardiovascular risk. Again, as I had mentioned earlier, we do feel it's a little less with the antagonist, but it does exist with both, especially for being on long-term use. So it is somewhat problematic, having the lower levels of continuous low testosterone and the associated risk of the increased cardiovascular concerns. So there's really optimizing, various risk factors, including like diabetes, high blood pressure, and their cholesterol, to try to minimize the risk. And certainly if people, need to make sure that they're getting plugged in with their cardiologist. And then some various endocrine effects, such as diabetes, some of the other drugs that are out there may be associated with some thyroid type issues. So just making sure that, you're screening for, and they're having appropriate follow-up with the that care team, as we mentioned earlier.
Yeah, thanks, Kara. I think that was a great synopsis of everything. And going back up to the top with fatigue, and you mentioned exercise with that. I mean, that is something I try to bring up every single time. And I certainly learned that from Dr. Moses. And, just looking at this list, I find that men who are staying active, whether that's going for a 15-minute walk every day, or working on their farm or their garden or whatever they do, I find that it helps with their fatigue. I encourage them that that's going to help the bone mineral density loss. It's going to help prevent osteoporosis. It's going to help prevent weight gain. I think exercising can certainly help with cognitive decline and cardiovascular risk. So, like I said, I try to bring that up every visit of what are you doing to try to be active. Really important. And then back to the risk of osteopenia and osteoporosis, we recommend the same thing: the use of calcium, vitamin D. If we need to go up from there with a denosumab or something like that, then we will. The AUA recommendation is to repeat bone density scan about every 2 years. Is that about what y'all are doing in your practice?
Yeah, it seems like that's really what's covered by insurance. It looks
Yeah.
like there's sort of a few questions around that. So the answer is yes. I'm getting a DEXA scan on everyone
Mhm.
who I am starting ADT therapy. If it's I mean, we really are pushing in our practices, if they're going to be on ADT for at least a year or more, that they should have it. If it's going to be less, I mean, I have a discussion with a patient. I sort of offer that to them, but I don't really necessarily push it if they're not really interested in that. But as I mentioned, there's a lot of people who have these baseline issues. So I feel like most patients elect to get it more than not. And
Mhm.
then if their DEXA is normal, I personally do not usually start denosumab on them. But it is technically approved for anyone who is considered high risk. So if you feel that there's someone frail, but for some reason, or you're just worried about, maybe they have, I don't know, whatever other concerns that you have, it is an option to start that without having bone metastasis, like we were just talking about in a localized setting. But certainly if they had metastasis, then that's a little bit of a different story, and starting that would be pretty standard.
Yeah, and so I do see the question. we get a baseline DEXA scan, and then, like I said, repeating bone density scan or DEXA every 2 years while someone is on ADT. Let's see if there's DEXA can be done more than every 2 years, but insurance might give you some pushback on that. So, okay. All right. Let's move into, oh, let me go back. There we go. The multidisciplinary approach in treating men with advanced prostate cancer. Again, this is I could probably add 10 more people to this list. But certainly the urologists, advanced practice providers, medical oncologists, radiation oncologists, those are the big ones. But Dr. Moses, who else can we utilize in a multidisciplinary approach in advanced prostate cancer?
Yeah, definitely. So you certainly closely partner with medical oncology, radiation oncology, also nuclear medicine. So some of the scans we get come through nuclear medicine, as well as some of the therapies we use, including lutetium or radium, are done by our nuclear medicine colleagues. Our specialty pharmacy is extremely helpful. They can talk patients through side effects of medications. They also look at any kind of problems with taking medication, cross-reactivities. And then they also interact with either insurance companies or industry to try to help reduce costs, which can be tremendous in these patients. We're on an APP talk, and I think that goes without being saying, but certainly in running your clinic, your entire team should have someone who is familiar with your patients and familiar with the guidelines, because a lot of the management is really done by your APP team, who can help guide patients through this, especially if the physician is having to see a lot of new patients and needs to get through your clinic day. Ideally, you have friendly relations with your palliative care team, because again, some of these men, even if it's not necessarily end of life, they need goals of care. They need to work through some of the symptoms that they're having. We refer patients to cardio oncology because of the cardiovascular risks of being on ADT. So I think that's pretty much our major team. And then you want to communicate with your primary care physician, especially if they somehow randomly get a PSA and it's 23 and they freak out. But what they don't know is that the PSA was 1,000, the week before. So, keeping them informed as well can help with sort of the routine outpatient management.
Yeah, and a couple other people I would add to this list, genetic counseling, especially all that talk we did on germline testing and helping, and especially in the setting of the information for the patient's family, and then also physical therapy, whether that be pelvic floor physical therapists after radical prostatectomy to help with urinary incontinence. Use them all the time. They're really incredible people. But then also our men with advanced prostate cancer, and especially the older gentlemen, where the last thing they need is a fall. So if we can send them to PT to help with balance or strength, or again, that just goes back to the importance of staying active in this disease state. Kara and Lori, do y'all have any other? I think we kind of hit everything there.
Yeah, I'll throw a few more for the more support side resources.
Yeah.
So social work is definitely a good one, as far as the emotional support, education. And I've also come to learn the value of just transportation for patients and connecting them with hotels. So there's a lot of things that I don't even think about, and even support groups, because a lot of these men just need to know that they're not alone. And I think we also use psych oncology, which is really important as far as especially people with a background of mental illness, or if they have any clinical concerns around their diagnosis, they're super useful.
Yeah, great point. And I know for us, the it's hard to get them into psych onc. You know, I wish we had 10 more of them available, but unfortunately, I think we have about 1 or 2. So trying to get them in is a battle, but if utilizing them is just can be incredible. All right, let's
You
see
mind
if we have,
back?
sorry,
There's a few of the questions. I don't want to get too far away from them, if you don't mind.
yeah.
So one of the questions, and I answered this, but there are some people online that don't see the chat. But there was a question about in treatment for de novo metastatic hormone sensitive disease. How long are you continuing therapy? And I think that was a follow-up from one of the intermittent ADT questions.
Mhm.
So ideally, these patients are on lifelong therapy, certainly ADT in combination with one of the novel hormonal therapy. There are some studies, and I mentioned Stampede, also one of the SWOG 1803, 1823? No, 1803.
1803.
That's directed therapy to the primary as well as oligometastatic disease with the hopes of reaching cure. So in those patients, they could potentially come off of systemic therapy. But for the vast majority of these patients, they're on lifelong. One of the other questions, any advice how to follow a patient who had a TERP with ductal type adenocarcinoma on the pathology specimen and PSA is normal? That is a interesting case, and we see that not infrequently. One of the things I do for those patients, I go back to the pathologist and say, you know, can you grade this? What are you seeing? What percentage of it? And if there's any question, I'll actually go and do a formal systematic biopsy. And if they've had an MRI, even a targeted area, because you really want to confirm the diagnosis, truly confirm if it's intraductal. And really the PSA doesn't matter. So at that point, again, if they have localized therapy, localized disease, ductal carcinoma technically puts them at high risk. So you would want to get the staging imaging, but then you would treat as a localized prostate cancer and tell the patient that they're at high risk for recurrence and you want to consider adjuvant therapy for them. And I'll answer 1 or 2 more and then we can go back. When do the side effects of ADT wear off or improve? It depends on what type is given for shots. If it's a 3 or 6 month shot, it takes almost as long or maybe even double that time to wear off because those are long-term therapies. If they're on oral therapy with Relugolix, it's fast on, fast off. So usually within a few weeks, those symptoms have resolved if their testosterone comes back. You got to understand, though, that the longer people are on hormone therapy, the less likely they're going to recover normal testosterone range. So if they're still having some symptoms, then it's likely that their testosterone is suppressed for a much longer period of time.
And we have patients too, Dr. Moses, that never recover, like their testosterones remain castrated and they just kind of have like this lifelong, level that exists in there. I don't know if you see that, but we definitely see that more than I was aware of.
Yeah, I've definitely seen that, and that's a hard conversation to have of
Yeah.
it's not looking like it's coming back, but have definitely seen it. All right, do we have any more questions in the chat that we need to get to? I think we're good on that.
Yeah, one more. So there was somebody made a note about focal ablative therapies, and yes, those are options for lower grade localized disease, but you have to understand that recurrence rates are higher and long-term data don't exist for that.
All right, that concludes our event tonight. Again, thank you all so much for coming tonight and have a great evening.